Welcome back to Paw Patrol with your host, Dr. Jeff Dykes. Tonight, I'm joined by Dr. Kelsey Millonig. Thanks for hopping on with me tonight.
Yeah, thanks for the invite.
Yeah, absolutely. So you and I know each other well. We're on a lot of committees and we run in the same circles because we are local to each other. We're both Iowans. But for the people who don't know you, why don't you introduce yourself and who you are and how you got to be where you are?
Yeah, so as Jeff mentioned, I'm Kelsey Millonig. I am proud Iowan through and through. So I grew up on a tiny little farm town in north central Iowa and stayed in Iowa for college. I went to Luther College up in northeast Iowa, go Norse. Played softball there and had the time of my life. And then following graduation there, I came to DMU. I was a dual degree student at DMU. So I did my DPM degree at the same time as I got my master's in public health. And at DMU is very, very involved in global public health, and had the opportunity to do an internship at the World Health Organization and some other unique opportunities through that, which was wonderful.
Mm-hmm.
After my time at DMU, I went on to residency out in Seattle, Washington, and then at Franciscan Foot and Ankle Institute with Dr. Byron Hutchinson. And then I went out and did my fellowship in Baltimore at the Rubin Institute for Advanced Orthopedics and the International Center for Limb Lengthening in Baltimore, Maryland. And thankfully, I was able to come back home and practice in the great state of Iowa. So I'm really happy to be back where I belong.
Mm-hmm. Me too. I think people who aren't from Iowa, never been to Iowa, they have a certain expectation or they just picture cornfields. It's like every time they show a sporting event, the B-roll footage is just cornfields. And I'm like,
oh, all the time.
that's nowhere near anywhere where I live or where I am. Like, what? And there'll be a football game at Iowa City and it'll be like cornfields. I'm like, where is that? How they had to drive 25 minutes outside of the city to find that. It's so weird. They like cling to this cliche of cornfields and field of dreams and all that stuff, but it's very strange to me. So you grew up in a small town and now you live in Des Moines and practice in Des Moines, and you're practicing out of multiple offices in private practice, and you have a couple partners that you work with. Is that correct?
Yeah, so I practice for East Village Foot and Ankle Surgeons, and like Jeff said, we have a couple doctors in our practice, and we have 3 locations. We have one in Mason City, Pella, and Des Moines, Iowa, and I primarily work out of our Des Moines office and then Pella as well. So it's really great to get out into those rural communities a little bit because that's where I grew up from. So it's nice to see those patients too.
Yeah, absolutely. They're a little less demanding, I think. When you get into the cities, people have higher expectations. When you get into the smaller towns, they're just happy that someone's there. They're just happy that someone is available to see them and try to help them. They're less demanding. What do you think?
They're so wholesome. I mean, they're just very appreciative. And most of them, when I tell them I grew up on a farm, all they want to do is talk about farming. You know, like, well, how are the crops back at the farm? Are you guys doing okay up north compared to us down here? And we go back and forth on that. I'm like, but we got to talk about your leg today.
Yeah. So maybe the stereotypes were correct and the B-roll footage of the cornfields is accurate.
You know, it's a good place. It's a great place with even better people. So I love Iowa.
I agree. So what do you think is the benefit of getting that master's degree in public health? What did you kind of want to do with that, and explain a little bit more what you were able to do with the World Health Organization?
Yeah, so interestingly, I really sparked that interest because during undergrad, I did a global health trip to Nicaragua with the Christian Medical and Dental Association. And that really piqued my interest in global health. And I decided to get my master's in public health because I thought that it would help me better serve as a global health practitioner. I could understand more what the communities needed, what was needed for long-term follow-up, maybe down to the basics of like, these people don't have clean drinking water, let alone ability to reconstruct a limb. How can we help them in those capacities? And it really kind of grew from there because my master's in public health has really helped me from a research side as a clinician. I've learned a ton about how to do appropriate research and integrating that. And then also on a larger perspective, I think podiatry is very unique in that we're both surgeons as well as in some ways preventative care physicians. You know, we see a lot of people for preventative care. And I
Yeah.
think that that really bodes well with your master's in public health degree. And so at DMU, you have the option that you can get that online. And so I did that simultaneous with my other degree while I was there. So it was really, really great experience.
I'm sure that opens your eyes to the rest of the world. We get a little tunnel vision, I assume, sometimes where we're just treating our own patients in our own clinic, in our own state, but opening your eyes to what the not so good health systems are that are outside of our borders. So you kind of once you open your eyes to that, I'm sure you kind of wish that, okay, well, now I'll go back to where we came from. We complain about our system a lot and the health insurance, but I think we have it better than you expect as soon as you start to realize what else is out there.
Yeah, I think that it's if you've done any type of, global medical work in any capacity, it's very eye-opening to see. And like you said, our health system comes with its own frustrations with insurance, but there is just a big difference taking care of patients that are just grateful that there's anybody that's showing up at all.
Mm-hmm.
Um, and I got to really see that. So I did an internship at the World Health Organization between my second and third year of med school, and that was a very unique experience that our global health department you could apply through with DMU. And I had the opportunity to actually live in Geneva for 2 months and work there. And I worked in the aging department there. And so I specifically looked at how different communities helped aging individuals for a master's in public health. And I got to kind of write some different policy work and see how that works from a top down perspective. Obviously, the World Health Organization is a huge entity, and
Mm-hmm.
how they can impact a difference through policy work and research.
And there's worse places to hang out than Switzerland. I've been there. It's beautiful.
Oh my gosh, it was stunning. It was incrable. It
Yeah.
definitely does not have the mountainous view that Iowa does. So it's, it's a little bit back and forth.
A little different. So I am not pro fellowship. I am not anti fellowship. I think that a fellowship can be fantastic. And I think a fellowship can be a negative in certain fellowships if someone is being taken advantage of for essentially cheap or free labor. The fellowship you did is obviously renowned for being one of the best in the country. And so no one would argue that that's not a fantastic experience. What was your mindset going into that additional year of training? And what do you think that it provided you that your 3 years of residency didn't, or what was above and beyond with the fellowship?
Yeah, I think that's a great perspective. And I agree with that entirely. I think that fellowships can be a huge benefit. And I also think that in some cases, they may be, just an additional year that is not beneficial to what you're going to offer your patients in the future. For me, I loved my residency program. I felt like I had excellent, phenomenal residency training. I was super happy with it. And I
Yeah,
was
great.
really debating what I wanted to do. So this is on the personal side, but my husband and I were long distance during this whole time. So he was here in Iowa, kind of expanding his career, and I was in Seattle. And so we were on our fourth year of long distance, heading into our fifth year because of the extern year plus the 3 years of residency.
Mm-hmm.
We were done with it. So we were trying to decide what we were going to do. And but I fell in love with deformity correction when I was a resident. I got exposed to external fixation. I got exposed to some complex reconstructive processes with Hutch. And because of that, I was like, I just have to pursue this to the nth degree because I really want to know everything there is to know about this. And there's no better place I can think of to do that than to go to the Rubin Institute in Baltimore. That being said, an additional piece of my fellowship that I did not get in residency was minimally invasive surgery.
Mm-hmm.
And because Dr. Noman Siddiqui was one of my fellowship directors. And with minimally invasive surgery, I mean, that fellowship year changed everything about how I approach my practice and how I help treat patients. And I mean, I couldn't be more grateful for that additional year to really expand my knowledge. I also loved, even though I'm not a city person, but I loved going from the West Coast to the East Coast the perspective and the dichotomy on how to treat patients is so different. I mean,
Hmm.
I'm sure that you experience that when we talk to our colleagues who are on different coasts and in different parts of the country. It's like
Yeah.
here in Iowa, most people do this, but then if you go to Washington, most people do this. And
Hmm.
I loved being able to take a couple of those perspectives and bring that back to Iowa. So that's been really fun too.
Well, I think that's probably best case scenario is if you're exposed to many different ways to treat something, then you can figure out what works best or makes the most sense in your mind. Whereas if you are going to one, I don't want to pick on any one city, but let's say we'll pick on Miami because they get nice weather and they got the beach, so they can handle it. But if
Yes,
you go to school
absolutely.
in, yeah, if you go to school in Miami, you do residency in Miami, and then you practice in Miami, you've never been exposed to how they do something anywhere else. You are only exposed to those things as opposed to getting that broader experience and getting, like you said, multiple types of exposure in different areas, I think is ultimately beneficial. I think some people get that a little bit depending on their externships, if they're going here and there and everywhere, but sometimes people do externships all in the same area on purpose because they want to stay in a certain area. But I think
Right.
that exposure is ultimately beneficial.
Yeah, and it's fun too. I mean, so now when I teach with Hutch or with Siddiqui or with Bebo or whoever, and we're talking on panels together, and they're like, "Well, I didn't teach you that," and I'm like, "I know, I learned that somewhere else, and I want to do it this way," and then we kind of get in this banter. But I
Yeah.
really like it because I feel like I get to take the best of all the worlds and combine them into my own.
Yeah, absolutely. You touched there on MIS, which you and I were just part of an MIS tournament. And I think that was a kind of a really interesting way to approach medical education in terms of quick presentation. And the focus was all on MIS. What role do you see MIS playing both now and into the future? Do you think eventually that every case will be MIS, or do you still see a role for certain things that really have to be done open, or what do you see as the future of MIS?
I think that's a really great question to entertain. I have a lot of, my partner will give me a hard time if I do any open incision, and he'll be like, "Is that the biggest incision you've ever made?" It's like, well, it's up
Yeah,
there.
yeah,
But I mean, there are just things that inherently have to be open surgery. I don't think that MIS is ever going to fully replace open surgery. And also, as an MIS surgeon who loves to figure out a way to do anything I can minimally invasive, I think that I think everyone should be a really great open surgeon before electing to do something minimally invasive.
yeah.
I
I
think
agree.
part of that is your experience too, right? Like what do you do and how have you trained on it? But I do think that MIS, especially MIS bunions have a lot of beef with them in different capacities. I know you've talked about that a lot on your podcast before, so we won't get into those details, but
I'm
um
just trying to get clicks. That's all it is. If you
I'm
make
a
people
big
angry, they'll click
believer.
on it.
I love that. And I do think that there's a lot of interesting conversation to be had around that. I definitely think there's a lot of expansive research that can be done on it. But for me, the reason I actually was not a believer in MIS when I went to fellowship. So I came from Seattle, and I remember having this conversation with Siddiqui. I was like, "Hey, I'm here for deformity. I'm
Hmm.
here for frames. I'm going to learn some flaps from Bibbo and some nerve stuff. I'll watch the MIS stuff, but I'm really not interested." That's the
Sure.
conversation we had when I first started.
Yeah.
And 3 months in, I'm seeing all of his post ops in clinic, and I'm like, dang, these look great. People are so happy.
Hmm.
And the more and more we got into it and discussed it and talked about deformity correction principles, I was like, wow, MIS is just utilizing deformity correction principles. It's using mechanical axis to drive everything that we do.
Sure.
And so now it's an entire entity, right? There's all these courses that are just on MIS and how to use it in different capacities. And I really do believe it's a mindset. I mean, a lot of people this weekend on cases were talking about, well, this is, kind of a combined open MIS approach because I needed to open this, but I'd like to do this MIS. And I think that that's really powerful. It's not an all or nothing thing. It's thinking about things in a different way. And I love that about it. It's so fascinating and fun to me.
Yeah, I'm a little bit older than you are, so I didn't even get the option to learn MIS in training
Hmm.
until I was forced to learn all the open surgeries. But I agree with you. It really is helpful to understand the anatomy with open approaches in order to then jump to MIS. If you've done enough open, whatever it may be, Lapidus, vertebrae fusion, ankle fusion, whatever it may be, then you have a better understanding of where the anatomy is, what you're trying to avoid, and what you're trying to target, specifically with the burr if you're resecting cartilage. And that makes you a better MIS surgeon. I'm a little worried as we move so far towards MIS that if people aren't learning the open approaches, that they don't have that kind of fallback plan of having to open it up and knowing how to do it a completely different way. Whereas you and I both understand how to do both of them. I'm a little worried. I don't know, worry is probably a little aggressive, but I'm a little hesitant that maybe we get to the point where some people don't even know how to do an open approach to do some of these things. You could maybe make the argument they don't need to because the patients do so well. But every now and then the MIS bird machine breaks or doesn't work or something goes wrong and you need to have a bailout procedure. But I agree with you. I think MIS is a mindset and ultimately it benefits the patient. I mean, I think there's a little bit of, podiatry is not overly flashy. We're not going to win any contests for being the sexy doctors, but MIS has some cachet to it, right? It's like, ooh, I did that via MIS. But ultimately, I agree with you, like you said, with Dr. Siddiqui's post-ops, that patients are doing so well. They have less pain. Their incisions are smaller. They're just walking quick sooner. They're just so much happier. So it is a technique and there is a little cachet to it, but I think ultimately it's just in the best interest of the patient.
Well, and I think that, I mean, that's ultimately what I tell patients when we talk about it. I'm like, there are a lot of ways that you could accomplish this goal, but by doing this with minimally invasive surgery, you have less pain, a faster recovery, better range of motion. I mean, there's just 100 things to put in the pro column for me, and patients love it. The small scars are like the secondary benefit, but it's the
Hmm.
sexy benefit that everybody wants to talk about.
Right,
But it's
right.
it's kind of the secondary benefit to everything else that we're doing with it. But I agree entirely. And I mean, I think in any case, you need to know how to bail yourself out. We talk about that a lot with deformity correction, with the use of hexapods and computer assisted programming. It's like, well, it's great that we all can utilize that and it makes our lives easier. But what if you can't? Can you do this with a traditional Alizaroff frame? I
Hmm.
think that's something that everyone should know how to do.
Yeah,
And so it's just kind of one of those things, like you always need to have your basis to fall back on and then expand up and open up your toolbox from there.
absolutely. You are part of or you were, you can fill us in on the details of the ACFAS leadership program. Why don't you
Yeah.
talk a little bit about what that program is and what the goal of being a part of that is?
Yeah. So ACFAS started doing this 2 years ago. This coming year will be their third year where they, select, you apply. It's a blinded process. So I'd recommend anybody who's interested to apply. And they select you to be part of a leadership cohort. So what you do is kind of throughout the year, you meet once a month and you talk about different leadership skills, leadership capacities, different ways that you can be more effective with patient care or with your staff, or for our national organizations as well, for our profession,
Hmm.
and really just get to meet a lot of incredible people through that process. And then, as part of that process as well, you collectively work with a group on a project that everybody finds important. So, some of the topics that we covered this year were, standardizing residencies, student nutrition, reimbursement, and foot and ankle surgery. So those are some of the topics that we talked about in different ways that as a national organization, ACFAS might be able to tackle those. And then we work with the committees on how, the organization might structure that. And so it's a way for you to get involved with the college and find a way to find like-minded people and learn a little bit about yourself along the process too. So I'm a bit of a self-development junkie. I have a problem. I consume way too much of that information,
Yeah.
podcasts, books, all the above. And so I think it was a really great program. I'd recommend it.
Yeah, it sounds Very interesting, and ultimately great for the profession if we have more leadership skills among the average population. So I think that's a fantastic opportunity for people to be a part of. I think I saw a picture and I recognized like the vast majority of the people on there. And it's like, yep,
Yeah.
yep, 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 yep. It's like a self-fulfilling prophecy. It's like, I always joke with my wife, Ashley, that the people who need to go to a health fair don't go to a health fair. If you're
Sure.
at the health fair, we're good. You don't need to be here. They're the people who need to be at a health fair aren't there, and the people who need to be in the leadership committee probably don't need to be in the leadership committee. They're going to be
Yeah.
leaders without the leadership committee. But I think it's a fantastic opportunity to help grow those skills. But I looked at all the people and I was like, oh, yep. They all, yep. Those are the go-getters. Those are the people that are going to rise to the top. So what's your favorite thing about podiatry? What drew you to podiatry originally, and what do you continue to like about it?
Oh, so my initial
Or maybe you
interest,
don't like it. Maybe you hate it.
yeah, I'm actually looking to get out. So thanks for bringing that up.
I quit.
My initial interest, I mean, because I'm sure you have this too. Patients ask you this all the time, right? Like,
Yeah.
why,
Oh, yeah.
why
Every
feet?
day. Every
Why
day.
feet? And I'm like, well,
Mhm.
there's a lot more disgusting parts of the body. So that's number one.
I
But
say no nuts, butts, or guts.
yeah, exactly. Um, I really was drawn to it because I liked, ironically, with how my brain works, I really liked the very isolated, very specialized part of this. I wanted to be in a profession where I knew like anything that you could think to know about one thing, right? If somebody had a question about it, I wanted to know the answer to it.
Mhm.
I would not have done well in any kind of generalized specialty or generalized care. I would have been a terrible PCP doc. I'm grateful for them. I just would not have been good at it.
That's a tough job.
Very tough job. And I, so that was one thing that kind of like drew me into it. I job shadowed an anesthesiologist when I was just a sophomore in college. He actually lives in Des Moines. We still have lunch once a year, which is
Mhm.
super fun. But and during that I fell in love with surgery, so I needed a surgical specialty, and I definitely loved that. But specific to the foot and ankle, I mean, just like anybody, I kind of had my own injury that led me down that path to start. But then once I got into it, I loved the biomechanics. I loved the
You're the
complexity.
one.
I
I was
am.
wondering who the one was of why they taught us all that stuff. You're the one.
Well, it's interesting, right? Nothing
It
works without
is.
ground reactive forces.
It is very
So
interesting.
I liked all the, I just felt like it was complicated more with how many joints there were, how many bones there are, obviously, the balancing of the tendons. I enjoyed that. And then as I got into it, my favorite part about podiatry is deformity and the complexities of balancing those ground reactive forces through a mechanical axis. So I have a bit of a sickness in that way, I guess, but it is what I enjoy. And my favorite part about being a surgeon is that you get to fix something, right?
Mhm.
People come in, they don't feel right, something's hurt, they can't do what they want to do. And we get to give them the opportunity to get back to it and get back to a life that they're passionate about. I mean, there's nothing better than that. I love my farmers that come in and then they send me pictures. They show me pictures on their tractor. They're like, look, I'm back up on my tractor. I'm like, you're not supposed to be yet, but great. I'm happy.
Right.
So I think that's why most people do what we do, but that's definitely my favorite part.
I agree with you. I have always been drawn to the instant gratification. The hard part, not only is family practice a difficult job, but there's a lot of, oh, you have this. Let me click this button. You'll go to the pharmacy, you'll take that medicine, and hopefully it works, but it didn't work all that well. We need to adjust your dose. There's a lot of like fine tuning. Again, it's very complicated, but we are able to provide that instant gratification. You came in, your foot was way over here, and now look where it is. Your foot was broken into 9 pieces. Now look, it's in better alignment. I walked in with pain and I walked out, post-op, however many months later, with no pain. Just that semi-instant or instant gratification for people is so rewarding for you as the provider to be able to see that instant turnaround for those patients and how appreciative they are. Some are more appreciative than others. Some kind of are just like, all right, yep, see you, bye. And some people are like writing letters and telling you how they changed their life. And it's really gratifying to be able to make that difference and then feel the appreciation from those patients.
Well, and even like I mean, I grew up in a small town and now I live in Van Meter in a small town outside of Des Moines. But like if I love seeing people in the paper, like kids that you treated, sports med kids, and you like see them like make the all-state team, or oh,
Mm-hmm.
they committed to go play Division 1 baseball or whatever, and you're like, yes, this is
Yeah,
awesome. Like I
right.
get to watch you fulfill this awesome dream after an
Yeah,
injury, and it's great.
it really is cool. Um, you're in private practice. Let's talk about that for a little bit, because there's a lot of different models that people can go into. But what drew you specifically to private practice?
Yeah, this is kind of one of those things, just like MIS. I don't know that I ever foresaw myself in private
Sure.
practice.
Yeah,
I
sounds
didn't,
right.
sounds like a right word.
Yep.
I didn't foresee this happening for me. I thought I'd work in a big entity in a large hospital system, to be honest, just based on my interests, and what I like to do. But the more I worked in academic medicine as a resident and a fellow, I recognized that there was just probably some limitations for things that were really important to me that I wasn't going to be able to do in that setting. And vice versa. That's, the case in private practice. You give up some of those things too. So, for example, I really enjoyed doing level 1 trauma during fellowship. I do very little trauma in my practice from a level 1 standpoint, right? Nobody's calling me at 1 o'clock in the morning for a pilon to throw a frame on it.
Mm-hmm.
Um, it was enjoyable to do, and I feel like you can make a big difference, but it's not part of my practice now. What I love about private practice, or specifically our private practice, is I really feel like with this, and I'm a small town kid, so I feel like this is part of it, but I feel like in that small cohort, there's a lot of controllables that we can control. You can control
Mm-hmm.
your staff. You can make sure that, hey, this patient, I need to make sure this and this get done in this order. And there's one person I have to ask to make sure that that happened appropriately. So I
Yeah.
just feel like our patient care is really, really phenomenal. And I'm really grateful to we have a great team. And that makes a huge difference. And I love that about private practice. I just feel like it's more intimate and patients feel like family in a lot of ways. But it also, every setting has its challenges, just like anybody in academic medicine, I'm sure would say. Like some people are like, I don't want to be in charge of any of that. I just want to see patients and move on. And that just didn't fit my portfolio.
Yeah, I think the benefit, like you were alluding to, is the autonomy and the you're in charge and you can do things however you want. I think there are some good hospital-based jobs out there. I know lots of people who are happy in those, but sometimes you become a little bit lost in the system, a little bit lost in the shuffle of a hierarchical organization that may be quite large, and you're just a number on the piece of paper. That happened to my wife when she was at her previous orthopedic group that got absorbed by a hospital, and then the hospital merged with another hospital system, and then it got bought by an even larger hospital system. And all of a sudden they'd never met her, they didn't know her, she was expendable at that point. Oh yeah, we can get rid of them, and them. And it's just a small example of the autonomy that you have in private practice that's never going to happen unless you choose to sell to another group. But you're
Right.
not just going to get come in and get, no one's going to come in and just buy you up and then all of a sudden you're an employee and then they tell you everything that you have to do. So remaining independent, I think there's a lot of benefit there.
Yeah. And I mean, it certainly comes with its challenges. Insurance is a challenge for independent practices. Absolutely. When you're not in a large entity,
Yeah.
and you don't have a lot of the absorption and flexibility if your staff members call in or whatever it might be, and you have to generate a referral base because you don't have an automatic one coming from a huge entity either. So there is definitely pieces of that make it challenging, but for me at least, the pros outweigh the cons. And I've been very, very happy to be in the setting I'm in. It's been great.
I think that's ultimately what anyone listening should take away from this is everyone is going to feel comfortable in maybe a different situation. And as long as you find the situation that you're the most comfortable in, that's ultimately what it should be. Like, I'm in a multi-specialty group, and just like you, I love my situation. I'm like a little mini private practice in a
Yeah.
multi-specialty group, but because we're physician owned, but still with that autonomy. So I think it's important for people to find where they feel comfortable and stick with it.
Well, and I also think what's interesting about this, that at least I don't know what your experience was, Jeff, but for me, everybody told me, like, you don't want to be in private practice. You don't want to be in this specific setting. You want to be in a larger group or whatever. And specifically because I specialize in deformity and limb salvage and kind of some of these more complex things. It's like, I can't tell you the number of people who told me you're never going to be able to do this in a private practice setting. And I feel so fortunate and that I still kind of took that leap of faith to just see if we could make it happen in the right way, in the right entity. And it's been nothing short of amazing. So very, very grateful for that. So I also think if you're listening, it's okay to explore different options. And, your mentors are looking out for your best interest, but you can look at a lot of things.
Absolutely. That's why shadowing's so important, and externships, and paying attention to who's working for what system. Oh, this attending works for the hospital. This attending's in private practice. This attending is whatever it may be, and kind of getting a feel for those as you're going through your training, because a lot of times people show up for their first job. Maybe they love it, maybe they don't. And then maybe they could have done a little bit better job of figuring out, okay, this is maybe for me or this is not for me. But it's hard. Sometimes you don't know what situation you're going to feel the most comfortable in until you actually get there and show up and start doing it. And then you realize, yes, this is great, or this isn't quite what I anticipated. And you start looking around for other jobs, and that's okay too.
Yeah, and I think, that's the case for many people, right? Is figuring out where that position lies. But the more you can see that during training, the better. So I think it's a huge benefit if your program lets you work with a lot of different people in a lot of different settings. That's such a benefit.
Absolutely. You want to jump into some cases here?
Sure. So Jeff and I were kind of talking about what would be some interesting cases to talk about today. And one of the topics we landed on was uncontained shoulder lesions of the talus. So obviously we can all agree that osteochondral lesions are quite a challenge, but that a contained osteochondral lesion, there's some reasonable choices for, but an uncontained on the shoulder is incredibly complicated in my opinion. And I, I
100%.
I always have to take a little bit of a deep breath when I see these come into clinic and to prepare the patient for the conversations that we're going to have.
Yeah.
So,
So
one
let's talk
way,
about
yeah, go
let's
ahead.
talk about uncontained real quick for any of the younger people. So basically, the analogy that I've used before is a contained lesion would be like a pothole in the middle of the street where you're having 360 degrees circumferential support around it, versus a curb. If a chunk of the curb fell off into the street, it's harder to hold that curb back up versus filling a pothole. So one is contained, one is uncontained, which means the shoulder lesion is a little more unstable and it wants to slide down into the gutter depending on what kind of treatment you're choosing.
Love that. I use that same analogy for the road. Everybody knows
Perfect.
what a pothole is. Everybody hates construction.
Exactly. Exactly.
So, one of the ways that I've tackled this is with partial talar shoulder allograft reconstruction, and we can kind of talk about the nuances of that, but I think it's useful to do it with a case. So, this
Hmm.
is a case of a patient of mine that actually just got published maybe a couple months ago in clinics just on uncontained shoulder lesions. And this is a
Hmm.
case that I put in there. But so, this is a patient, she has had 4 previous surgeries. So she has a tibial cyst that you can kind of see just sitting right along that tibial plafond. And then she's got this medial lucency in her talus. And the previous surgeries have all primarily consisted of scopes. And with the scopes, she's had microfracturing, she's had some different biologics placed. But for uncontained lesions, those are really still difficult ways to repair an osteochondral lesion.
Hmm.
So this is what her MRI showed. And obviously, when we look at this MRI, this medial talar shoulder does not look happy. That medial
No.
talar shoulder has a ton of edema, cystic changes, and I think particularly in the coronal view, you can really see how much of that talar shoulder is damaged.
Yeah, it's pretty deep.
Very deep. And so when you look at this, I mean, even if you can potentially, sometimes you can fix some of that subchondral edema if it's a contained lesion, right? By doing some variable options. But with this, I don't think that those are suitable for that. So this is a tough problem. And some considerations that I make, she's in her 60s. So we did talk about the potential for a total ankle replacement. But she had that tibial cyst, which you can see better on some of the cuts I have with the CT scan. And those still have those still have an end life, right? They still don't last 20 years. She's very active. And so we were trying to find a suitable option for her that might be a reasonable choice, which is for me where that talar allograft comes in.
Sure.
Okay. So now on the pre-op CT, I do like to get both CTs and MRIs on this. I don't know. We can talk about that a little bit, but for me, I want to see go ahead.
Yeah, go ahead. No, I was gonna say, what are your thoughts on that? Because I think that's reasonable you explain what your thoughts are.
Yeah. So for me in these scenarios, MRIs are going to really show a ton of edema, which we want to see, but I really want to know what the bone structure actually looks like to know what I'm working with. Is there a cystic bone that extends all the way through, over half the talus? Is it contained just to the shoulder? What are my treatment options for that then? And so I get an MRI and a CT whenever I'm dealing with an osteochondral lesion of this capacity.
Yep. I think that's very reasonable.
I will tell you it can be tough with insurance. So I typically do order them at separate times.
Sure. But it's giving you a little bit different information. And when someone has failed multiple surgical interventions and then you're moving towards salvage is not quite the right word, but you're getting into the more advanced, talar allograft, you need all the information possible. So I think it's very reasonable.
Yeah, I agree entirely. So for medial OCDs, obviously a medial takedown is a pretty standardized approach for this. I have done and do know clinicians as well that will do this through an anterior approach and leave that medial mal intact, which I love the idea of. I think that that's easiest done if you do an X-fix assisted distraction of your ankle, like with a unilateral frame.
Sure.
I have a difficult time getting approval for that in the entities that I operate in. And so I typically will do a medial mal takedown for this. I also think it does just provide you the best visualization to make sure that you're getting that cartilage intact.
Sure.
With the medial mal takedown, though, I would say that from my standpoint, it's imperative that you pre-drill the medial mal and make sure that you have that so that it's fixated exactly where you want it to be when you go to put that back in place.
Yep, I agree.
So
That's
here you can
good visualization, really good visualization there.
It's great. So here you can see I cut out the damaged portion of the talus, and when you do this, again, in my opinion, it's important that you take really the dorsal medial entire portion of the talus, and that you don't make this fragment too small because it will have difficulty healing. So here you can see the damaged portion of the talus in that upper right hand picture, and then a size match talar allograft, which is also based on the CT scan. Another reason to have a CT scan and another better way to get approval from insurance is saying that you need it for that purpose. And then here you can see what that looked like with those side by side when they were going to get implanted. So the damaged portion versus the talar allograft portion that I cut out. And this is really size matched based on what you resect. So you resect first and then measure. You always, of course, measure twice, cut once, but also make sure that you cut a larger segment than a smaller segment here. So you can always kind of fine tooth this and trim that down, but you can't add it back once it's gone.
Right. That's good advice.
So, temporarily fixating that talar allograft piece in place. And then I have been more recently electing to do these with a osteofiber. And so this is actually something that is will become biointegrative. So it doesn't disrupt your imaging in any way, which is great, especially for this talar allograft, to know if you are going to end up with any type of sclerosis or AVN of this segment is important to catch early. And so I like it for those reasons. It's also really easy to get this flush and actually a little bit depressed within the cartilage. And
Mm-hmm.
that's important for no matter how you choose to fixate this, that is depressed.
Yeah, countersunk. It's below
Yes.
the surface of the cartilage.
I do want to make a point too that some of my colleagues and friends fixate these by putting screws and not putting them through the cartilaginous surface at all. So throwing those screws, the other direction. So you're
Mm-hmm.
not disrupting the cartilage in any way. I think
Mm-hmm.
that's a very great idea. I think it'd be very difficult to do with the fixation that I chose to be able to look at it on imaging without being disrupted by metal. But I think that that's an important topic to maybe converse about and see. I do think it's a little bit more difficult to identify exactly the angulation of your screws, but I think that that's a good choice. I have not done it that way in the past, but we were just discussing it after with some friends at a conference, and somebody brought that up, and I was like, yeah, I think that's a good point.
Yeah, I think that's reasonable. I would go along with what you did here and get that direct visualization. And there's something about getting that direct compression versus the indirect compression. I always feel like the direct compression is much more stable and reliable than relying on that indirect where you're coming from another angle and hoping that those threads engage and pull it down. I'm a much bigger fan of direct compression. It just feels more reliable in my hands. But I completely agree with what were you going to say?
No, go ahead, Jeff.
I completely agree with your fixation choice here. I've used, chondral darts and different types of things, but I think this is a fantastic option specifically for this indication. Do you anticipate that cartilage will grow over top of those screws, or do you not care if cartilage grows over top of those screws over time?
So, two things. One, I agree with the direct compression and direct visualization for this allograft. That's another reason I still like opening it too, is because I want to see that surface actually looks fluid across that cartilage. Two is, do I think that cartilage is going to grow across these? No, I don't. Do I think that it matters as long as they're countersunk? No, I don't. Is
Right.
there potential that we could, maybe add a biocartilage or a glue on top or something to that?
I was thinking exactly along those lines. Is it necessary or not? I don't
Yeah,
know. I don't know the answer.
I don't know the answer either. Intuitively, I would argue no. I think that a fibrin glue might be helpful along the allograft shoulder, actually, along kind of that entire cut, which I've
Mm-hmm.
not done in the past, but I have considered. But I think
Mm-hmm.
that these are small enough and buried that it doesn't matter. It doesn't affect the articular surface.
Are you trying to match the allograft level to level, or are you anticipating any amount of settling with these over time, or what's your goal when you line up the allograft with the native talus?
Yeah, so you're almost always going to end up with some type of settling of your allograft, right? You're going to get some type of um, it's going to shrink a little bit down. And so I would say that if you can leave it like a millimeter proud, that's probably ideal. I
Mm-hmm.
think if you get it darn close, you're still going to be happy with it, but leaving it a little bit proud to start is the better angle
Sure.
on that.
Absolutely.
And then I fixated the medial mal here. You can see the exact same way I threw those osteo screws in. And something imperative about medial malleolar fractures that we talk about a lot is a buttress segment to this. So in addition to the two screws that went it directly in, I will say that these have less compression than a standard screw would for the medial mal, but I really wanted to be able to visualize everything. And so I did add an additional transverse buttress osteo screw across this. Um, just to prevent that glide. So an anti-glide screw rather than an anti-glide plate. And so I do think that that's something to talk about here too when you're doing these medial mal takedowns.
Yeah, I think that's reasonable. And so she's had this entire surgery with no retained metal, correct?
Correct. Correct.
Yeah. People like that. People like the idea
They
of
really do.
natural and turning to bone and all that stuff. They really like that. When I've utilized this technology, people really, they vibe with that, seemingly.
And interestingly, I feel like people have started to ask for it.
That's an interesting new twist to things like that.
So this is her post-op at the 22-week mark. So of note with these, I do keep my patients currently non-weight bearing for the 12 weeks. I
Okay.
have not yet attempted to speed that process up with these Taylor allograft shoulders.
I
But
think there's two schools of thought there. One is that you don't want to ruin it. And number two would be that someone might say if the axial loading would cause some stress and actually cause it to integrate. But I would lean more towards your direction and say, if you mess this up, I don't want to redo this.
yeah, I do think that some of the axial loading can help with certain things, dynamization and those kind of pieces of the puzzle. But for this, for me, with that cartilage and the potential subsidizing of that graft, I don't want that to happen. I do
Yeah.
have them do range of motion of the ankle joint, when they're non-weight bearing to at least keep it moving. But you can see
Sure.
that this integrated really nicely. You can see kind of that where I filled in that tibial cyst and maybe some of the osteo tracts, but obviously I didn't use metal, so you can't see any of the hardware. So this is the patient's CT scan at 6.5 months, and you can see that integrated incredibly nicely.
Yeah,
Um,
that's amazing.
in every view, and she's full activity. She's doing everything she wants to do. She has no pain. So I mean, I've used this technique several times now in these kind of dire tailor shoulder uncontained lesions that have failed other treatment options. And I've been very, very happy with it. I've been very happy with the unobstructed view of the integration without the metal as well.
Mm-hmm. Yeah, I think that's a fantastic technique. This looks awesome. And you can't even really tell on the coronal view where the graft stops and the native talus begins. So that's fantastic integration for her. And it'll be interesting to kind of look at them. I believe the technology says that it'll fully integrate over 2 years.
Yeah.
So it'd be interesting to have her back at about 2 years and see if you can see anything. You already can't really see anything at all, but it would be really interesting just to look at a normal appearing X-ray 2 years after an X-ray that looked horrific. It'd be pretty amazing.
Yeah, I've tried to convince her to come see me every 6 months so I can just re-X-ray it and then eventually get another CT scan just because I want to follow this long term and be able to see
Mm-hmm.
what this does. But really powerful for a really challenging topic, and I think can be useful for a lot of people. I first saw this technique during fellowship, and I've been very happy to have it in my arsenal for some of these cases.
Yeah, I think it's a great technique. I think for her, your options that we already talked about were essentially tailor head, partial tailor head allograft, ankle fusion, or ankle replacement. And so to maintain native function of the ankle, I think is optimal. I mean, people do pretty well with total ankles, but and they do pretty well with ankle fusions as well. But I think this is kind of the prime choice for her, as evidenced by the fact that it turned out so well and she's so happy. So it's a
Yeah,
great
and
case.
I think that part of this too is choosing your patients. She had a great metabolic capability to heal bone. I think in some patients that's not the case. And in those situations, maybe a different option would have been a better choice. But I always choose the native ankle if we can help it. So
Absolutely. Are you checking vitamin D on people preoperatively?
I do. I
Every
check.
every fusion, not every patient, but like what maybe every patient, I don't know, but I see so much vitamin D deficiency and we practice very close together. And so if I'm seeing it, you're seeing it, and it is just so prevalent.
Yeah, I check it on anybody who's having osseous work. Anybody.
Mhm.
And I would argue that I find a ton of vitamin D deficiencies.
So often.
I don't know if Iowans just don't go outside or if all we do is wear hats and long sleeve shirts, even when we're baling hay in the heat of summer. So I guess that's why, I guess. I don't know.
Yeah. I don't know what it is either. I don't know if it's the hereditary lineage of the people avoid the sun because they burn. I don't know what it is, but we are not South Beach people. We are
No.
turn
No.
red in the sun people, and most people try to avoid the sun. But whatever the reason is, I see so much vitamin D deficiency, and all the time I do a fusion, and then I'm looking at it, I'm like, I thought I did a good job, and I'm looking at it, and then I check their vitamin D, and it's like 12, and I'm like, oh. So checking more and more vitamin Ds, and even checking them pre-operatively on these patients, I think is important.
Yeah, it's part of my preoperative workup for most patients, and I have everybody supplement before I even check them, just because I know that they're all going to be low in some capacity. And honestly, it's pretty difficult to get a vitamin D toxicity. It's not impossible, but it's pretty
I've seen
difficult to obtain.
one time I had a lady who was high. She wasn't toxic. It was a little high, but one time ever of checking many has it been too high. And she was taking some wild supplementation all the time in order to get it high, meaning you can take a lot of vitamin D and still live in a very normal range. Or I honestly have some people who do take OTC supplementation and it's still low, which means they're not, that gets complicated by metabolically in terms of figuring out, they have a malabsorption disorder or something. But even the people that are supplementing sometimes come back low.
Yeah, and also your ranges, I mean, I have some facilities that send it back and they say anything that's over 20 is appropriate, and I would disagree with that entirely. I'm
I
looking to
agree.
get something around the 40 range if I'm doing
Yep.
bone work. So I think
Mm-hmm.
that that's also important. Don't just take it for at its face value. Actually decide what you want the value to be.
100%. I want everyone above 40. I agree.
So
Well, thank you for hopping on tonight. We have an incoming thunderstorm, and we're probably going to lose power here in a minute anyways. So probably not. We'll be fine. But thank you for hopping on the podcast tonight.
yeah, this has been really fun. Jeff, you have a really great platform here. So thanks for the invite.
Absolutely. If anyone wants to reach out or get in touch, tell people what your Instagram handle is.
Yeah, you can find me at Iowa Foot Doc. Pretty simple. And I'm on most of the social media platforms, so you can find me there.
Absolutely. Check her out. And thank you for joining me tonight.
Thank you.
Yep. Joining me is Dr. Kelsey Millonig. Thank you, everybody, for joining us on this episode of Paw Patrol with your host, Dr. Jeff Dykes. We'll see you guys next time.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.